Okay, great. Thank you very much for the kind invitation and the um, possibility of sharing some of our experiences with the audience. Um, we've been using adipose-derived tissue derivatives for about 6 years, maybe close to 7 years here in UAE, and the following slides will just show some of our experience. Here are my appointments. I work at Health Point Hospital, which is in Abu Dhabi. I've been there for about close to 2 years now. Um, Here are some of the other organizations that I'm involved with as well. Um, I'll go ahead and jump right into the topic. We all know it's quite clear that osteoarthritis is a big issue facing many countries, not only in the West, but also in the eastern part of the world. In the U.S., those costs are astronomical. The average medical expense to manage someone with knee OA is about $2,000 per month. The lost work and earnings is a staggering $80 billion per year. Over 30 million people are affected, U.S. adults are affected by this condition. And not only that, about 25 million of those individuals have some kind of limitation of their activities because they have arthritis. Now, this also makes the management of other chronic diseases, such as diabetes and heart disease, difficult because of the patient's inactivity. So right now we have about 30 million people that have osteoarthritis, but in 2 decades, this number is going to be even greater, up to about 80 million people. And so how are we really going to be able to manage this and manage it with the resources that we have? Right now, the end-stage total knee replacement, it's a end-stage disease management procedure. And what we saw earlier in the earlier talks, in particular with Conrad's talk, is that we're starting to see the onset of disease even as early as the third decade of life. And so what does that mean for our societies and for orthopedic surgeons? That means that we're seeing earlier and earlier people undergoing end-stage intervention at a younger age. And I can tell you that it doesn't work. Total knee replacement, even though we're starting to see most of them done as an outpatient in, say, in the U.S., is still associated with significant morbidity and mortality as compared to non-invasive interventional procedures. The cost is also staggering. This slide shows $50,000 for knee replacement, but there's some numbers that we see elsewhere that show that it's a little bit less. But the issue is, even currently, performing a knee replacement in the U.S. Is not cost effective. And if you want to go to a really nice place like HSS or Hospital for Joint Disease, you'll end up spending 4 times more than what's listed here. So we know that for this procedure to be effective, as far as from a cost standpoint, the cost needs to be less than $14,000. And right now, the average cost is about $26,000. And so the only way that this really works is if we are performing this procedure on patients that have the most severe disease. And most of these people are a lot older than some of the 50-year-olds and 40-year-olds that we see undergoing the procedure. We know that performing knee replacement is far better from a cost perspective late than early. And this translates to about $8,000 US if we can do this procedure later rather than earlier. Another big issue and special topic, especially since we're talking about joint preservation, is kind of a high level of I don't know the best political way to say this, but basically, orthobiologics are not getting a fair chance. And a number of the organizations focus on arthroplasty. The hip and knee surgeons, Hip Society, Knee Society, also the American Academy of Orthopedic Surgeons. They're basically likening this treatment to snake oil. Like we are selling things that don't work, that don't have evidence. And this is just the furthest thing from the truth. And I actually wrote an editorial this month about this very topic because their commentary that we have no evidence, especially in advanced hip and knee osteoarthritis, is not true. And they should really modify their position statements on this and actually get behind and support this, because currently doing knee replacements on someone who is really young, it doesn't work. And so, as I mentioned, we wrote this in the Biologic Orthopedic Journal. And, if you're really interested in the conversation, I encourage you to come and join, maybe review papers or get more involved. Send in your papers. We'd love to help support you. There's no article processing charges for any submissions. And so we're really there to help you to publish your work. But there's compelling evidence that orthobiologics are both safe and effective, and it's just being ignored. And so this is a slide that Jerry Malanga from New Jersey made back in early 2020. And now it's 2021, and I know of at least 20 additional studies that have been published since this paper, since this slide has come out, this infographic. And at that time, there were over almost 6,000 patients that have been treated with adipose tissue derivatives for treating knee OA. And so as early as 2011, so all the yellow are the patients for micronized fat, and the green are the studies with SVF, and the blue are the studies with adipose-derived or culture-expanded adipose-derived stem cells. And so I'm not going to spend a lot of time on harvest because we got the leaders of fat harvesting talking earlier, so I'm not going to waste time. But let's just talk about some of the evidence. This was a nice study published in 2020, and it showed different kinds of osteoarthritic patients, both of the patellofemoral joint as well as the tibiofemoral joint, with 12-month follow-up. And what they saw in IKD and KOOS scores, you had a significant increase in 70% and 67% of the patients, respectively, of those scores. Another study, this was another one-year follow-up published in 2020, including mild to severe OA, 91 knees. And what they noticed, they had about 50% response to therapy at 1 year. But if they took out all the patients that had bone marrow lesions, that improvement, the number of patients that responded to treatment increased to 75%. So I think that's pretty impressive for just a one-off injection. This is a study out of London by Nima Hardari and Ali Noorani. They had 110 knees, a larger spread in age group 42 to 94. And what they found at 1 year follow-up was that they had significant improvement in pain, function, and quality of life. And it included all types of knee OA with 1 year follow-up. This is a study that we just published. It involved 5 centers, 3 in the U.S., 1 in Milan, and my data from UAE. 75 subjects, 120 knee treatments. Average age was 70 years, but we did not include any patients that were younger than 60. So we wanted to look specifically smack in the eyes. We wanted to look at the patients that would be good candidates for knee replacement and see if the micronized fat could be effective in mitigating their symptoms of disease. Now, the BMI, the mean BMI of this group was 28.4, which is really important. Again, we had KL2s through 4, 24-month follow-up. And what we found for KOOS pain is that 88.3% has significant improvement. Only 9 patients in this follow-up period went to total knee replacement. And this is patients that the average age is almost 70. And the other piece, we did a cost analysis comparing doing micronized fat to total knee replacement. And we found that micronized fat had a $2,000 per point increase in KOOS advantage over doing a knee replacement. So if you have a patient that even has advanced osteoarthritis, this could be a viable solution. And I'm not saying that we should do it primarily on these patients with advanced OA, but it could be a treatment that could work for them. The other piece that we found in this study is that females did better. We think this is really a surrogate for activity level, because if a patient had a higher pre-treatment activity level, this was a risk factor for failure. And so we think it's not with gender, but really that the patient may have a different level of activity. Guys may be a bit more active than ladies. So again, we saw significant improvements in pain as compared to baseline out to 24 months across the different domains of the KOOS. And this is another important paper published by Jerry Malanga looking at meniscus tears. We know that we shouldn't be operating on them because there have been a number of studies since the late 90s that have shown that we should not be scoping arthritic knees. And in my mind, osteoarthritis starts with degenerative meniscus tears. And this was a nice study in 20 patients, average age 60 years old, BMI less than 30 again, follow-up 12 months, had a 20-point increase in mean KOOS scores and more than a 2-point decrease in numerical pain score. So if a patient has a degenerative meniscus tear, this can also be a possible treatment. Now, Conrad talked about SVF and also Professor Tremolata, so I'm not going to spend a lot of time with this, but I do think SVF, I would like to investigate it myself, but unfortunately, most of the regulatory bodies here in UAE, it is not allowed. In the US, it's not allowed, but we've had a number of really good randomized controlled trials that have been done, and we should be seeing these papers come across soon. We recently did a systematic review and meta-analysis looking at SVF. Most of the patients we had to exclude. There are over 4,000 patients that have undergone this treatment. And so we looked basically at 290 knees and 200 patients out of 11 studies with 3-month to 6-year follow-up. And the majority of patients had improved pain, range of motion, quality of life, and functional rating. Now, most of the studies are all positive. And as I mentioned, some of them have MRI evaluations post-treatment, like the BUI study. Also, the study done by PAC in 2011 also saw improvement on MRI. And so I'm not going to spend a lot of time on this, but I'm going to move on to culture expanded cells. We've used them since 2015 here. And in general, we use them for more aged patients because we feel like their available pool of cells may be less. Certainly, if a person has chronic disease, we try to avoid their use. And I think we should really think about developing assays for patients before treatment. We have been looking very cursorily at the cells of the individuals and seeing how they respond to different kinds of stimulus like anoxia, increased temperature, decreased temperature, increased CO2, and seeing how the cells respond. And if they respond more positively, we have an idea that they'll, their tissue activity is good. So if a patient's tissue activity, they have a chronic disease and they can't respond, I would not expect much out of these treatments. And I think we need to do a lot of work on that. And we'd like to use culture expanded cells when we anticipate multiple treatments. We find that this is helpful. Another benefit of culture expanded cells is that it's a product in the bottle. It has a cell count viability. We know the cell identities. And so we can go back and look, especially if you have a registry, and look and see the factors that may have been at play if a patient doesn't respond to treatment. And so this is a great thing about having the characterization with culture expanded cells. They could be stored as pretty much as long as you want, and they could be used as boosters, as many have chatted. And they come in a syringe like this, and it's easy. You can aspirate and then inject the cells. You know exactly what you get. What we've seen, we've used 10 million, we've used 20 million, 50 and 100. And even though I know I've been promising that I'm going to present our 2-year data, I've been promising this for like 2 years now, and I still haven't done it because I've been working on other projects. But basically, it seems my gut feeling is that the higher cell counts work better. But with higher cell counts, we also see higher increases in pain or mild adverse events after treatment. But in our patients, we have 31 treatments in 19 patients with a BMI of about 28. At the time of this last follow-up was 24 weeks. And where we saw the difference was in pain and activities of daily living. We saw about a 35% improvement in pain. The adverse events really nothing too serious, but again, with the higher cell count numbers, 50 million and 100 million, we saw more pain, and this would last for a couple of weeks, maybe 3 weeks. Now, there have been a number of studies with adipose-derived stem cells that have been published using culture expanded cells. The last one was Freitag in 2019, where he used 100 million cells, either in one dose or two dose. The MRI showed disease modification. Press in 2016, this is a group from France. They also had very similar results. The VAS scores decreased 32% in their cohort of patients, and that's about the same as ours. We didn't do WOMAC scores. So take-home points. Well, in my mind, the best responders, don't have mechanical malalignment. And I didn't really talk about that early in the talk. But I find that when we have severe mechanical malalignment, treatments seem not to work. And I think it goes along with the study from Belgium that looked at bone marrow lesions. With malalignment, I think you're much more likely to have bone marrow lesions, and these patients are probably less likely to respond. But again, we need better studies to really see that. BMI, I would recommend this kind of treatment on patients less than a BMI of 30. Females do better, but I think it's really more of a surrogate for activity level. And of course, lower grade OA did much better. Adipose tissue derivatives appear to be safe and effective for knee OA. The evidence is promising. It's mostly level 4 and 5. There's some limited level 2 and 3 studies, but I think we're getting there. KL grade 2 through 4 OA can be treated. And I think we can all agree that delaying performing a knee replacement has significant benefits, not only to society, but also to the individuals, which is most important. And if you have any questions at all, please use my email address. I'm happy to talk to you, or WhatsApp, and I look forward to seeing you and speaking with you.